Dr. Routray from Cuttack is Professor HOD. So Dr. Routray is going to speak to us on role of MRA.
As we all know, this is one of the pillars of treatment of heart failure, but one of the neglected pillar we can say. You see the mechanism of action of MRA, because mainly we call it aldosterone antagonist because aldosterone works in mineralocorticoid receptors, and whatever drugs we are going to talk, that is just antagonizing that this molecule. This MRA, that spironolactone, eplenon, quinolone, whatever they are in the use, they just antagonize the effect of aldosterone, thereby they improve fibrosis, improve apoptosis, improve inflammation, and improve heart failure. Coming to what are the goals? Why we treat heart failure? So improving survival, reducing hospitalization, increasing the functional capacity, mitigating the symptoms, ultimately improving quality of life. Does MRA help in all these things? The evidences come mostly from 3 major landmark trials, which have propelled this molecule to class 1 recommendation in all guidelines of heart failure reduced ejection fraction, the RAILS trial, EPHISUS, and EMPHASIS HF. If you see, the RAILS trial go back to 1999, which is spironolactone, and this is a randomized double-blind placebo-controlled trial of 1,663 patients, the class 3 and class 4 heart failure is EF less than or equal to 35%. Spironolactone was compared to placebo. The primary outcome was death from all causes. And what they found? The risk of death was 30% lower among patients with spironolactone group versus placebo. If we come to the heart failure hospitalization was 36% in the spironolactone group, whereas 46% in the placebo. When compared, all were statistically significant. In EPHISUS trial, which came in 2003, here there is a randomized double-blind placebo-controlled trial post-MI, and patients are included from 3 to 14 days. Within 2 weeks, EF less than 40%, 6,200 patients. Here, eplenon was used, the dose 25, then optimizing to 50. The primary outcome was death from any cause, death from cardiovascular cause, or hospitalization for heart failure. What they found? They found 15% reduced incidence of death due to any cause of heart failure hospitalization with eplenon, and 13% reduction in the incidence of severe cardiovascular cause of heart failure. And if you come to this last trial, this EMPHASIS HF, which came in 2010, here the effect of eplenon in patients with chronic systolic heart failure with mild symptoms. Here, 2,736 patients, EF less than or equal to 35%, and the primary outcome was a composite of death from cardiovascular cause or hospitalization for heart failure. What they found? Here, 37% low risk of hospitalization for heart failure or death from cardiovascular cause in heart failure patients with eplenon compared to placebo. Here, 23% low risk of hospitalization for cause of cardiovascular cause heart failure in eplenon. What you see here is the cumulative starting from the evidence, starting from the diuretics, digoxin, then coming with ACE inhibitor and SOLVE trial, gradually reduction, cumulative reduction in the mortality, improvement in the survival as is shown till MRA EMPHASIS HF in 2012, and after that we have added SGLT2 inhibitors, further improving the survival. So key points, cumulative data of approximately 12,000 patients with heart failure reduced ejection fraction, applicable to ischemic and non-ischemic etiology, mean age more than 60 years, mean EF less than 35%, substantial proportion of patients who are taking beta blocker ACE inhibitor ARB, both spironolactone and eplenon, maximum targeted tolerated dose as 50 milligram per day. And this is what they found. If you look at the death, hospitalization, all these things, hazard ratio is very low. If you see the functional status was assessed in RAILS trial, that also p-value is less than 0.001. But one important thing is hyperkalemia. If you see all 3 trials, RAILS 2% and EMPHASIS HF is 8%, highest EMPHASIS HF of hyperkalemia. However, in EMPHASIS HF it was seen, though 8% of patients developed hyperkalemia, only 1% withdrew because of adverse events. They are well tolerated. Looking at this estimated 5 years survival, number needed to treat to save 1 patient with beta blocker is the highest, is 8, with RNA it is 11, and with the MRA it is 15. And if you look at here, but the irony is MRA is one of the most commonly forgotten guideline recommended molecule in patients heart with reduced ejection fraction. It has seen in Kerala registry, only 45.9% were using MRA. Likewise, inter-CSF study in the Indian subset of patients, they were using 47%. Not only that, other molecules were also being used less. So this is mainly because the therapeutic inertia between the physicians to optimize to the medications. And this is Canadian study, it was seen only 40% of the patients, even in 2020, they were achieving the high air target or maximally tolerated dose of drugs like beta blocker, ARNI, ACE inhibitor, or MRA, only 40%. Now, coming to the role in heart failure preserved ejection fraction, more recently, NHLBI sponsored TOPAC trial that used spironolactone 3,445 patients. But however, in TOPAC was followed up for 40 months. The patients, those who had high BNP or NT-proBNP, or those were admitted earlier for heart failure. But they found they did not reduce the primary outcome consisting of cardiac death, resuscitation, cardiac arrest, or hospitalization, though theoretically they should be helpful. However, heart failure hospitalization had a significantly lower incidence in the specified population. Why I tell specified population? It was marked geographical difference. In the patients who were randomized from South America and North America, they helped, but East Europe, like Russia and Georgia, they were not found to be helpful. But now what has happened? This underuse of MRA in heart failure is mainly due to fear of hyperkalemia. So new non-steroidal MRAs, new targeted delivery of MRAs, new potassium lowering drugs, and new potassium home monitoring system has come up. So new drug is Finron. There are several drugs that have been tried. These are non-steroidal. So they are likely to have less of side effects, sexual side effects. They are more tightly bound to the MR, so that more specific effects, less of rising the HbA1c and all potassium. But this would be helpful in diabetes mellitus. One of the largest studied is finerenone. What they found in ARCH trial, finerenone was compared to spironolactone, was found to reduce BNP and NT-proBNP as well as urinary albumin significantly more than placebo, but similar to that of spironolactone. The incidence of hyperkalemia was less with finerenone. And the ARTS HF study where finerenone was compared with eplerenone, what they found, this 10 to 20 milligram of finerenone was found to reduce BNP and NT-proBNP as well as the incidence of albuminuria, and hyperkalemia was less as compared to eplerenone. And these other trials which are being taken care, like PETAGO and all this, they're addressing the further issues. And this is the future use of mineral corticoid receptor antagonist potassium binder for heart failure cardiovascular prevention of heart failure in patients at high risk. This HOMES study, the part of the study has come up recently where galactosine may be helpful to prevent development of heart failure. And like an alchemist study, the end-stage renal failure. All these are going on. So you can see the mineral corticoid receptor antagonist can be helpful and in the entire cardiovascular continuum. In the HOMES, it's regarding the risk factor, for the high risk factor, the preventing the heart failure, TOPAC, as it is helpful in reducing heart failure hospitalization in patients with heart failure preserved ejection fraction, and emphasis and all rails with severe heart failure, all it were helpful. What the guideline says, guideline recommendation will go to the 2016 ESC guideline that clearly says how this MRA antagonist to be used. Why should you use? To improve symptom, reduce the risk of heart failure hospitalization, and increase the survival. In whom and when? Potentially all patients with a persisting symptom of NOIHA class 2 to 4 and LVEF less than 35% despite treatment with the ACE inhibitor and ARB at that time. And how to use? Check renal function and electrolyte, because earlier studies they excluded patients with creatinine 2.5 and eGFR less than 30. Check blood chemistry and at 1 to 4 weeks after starting and or increasing the dose of MRA. And it should be followed up by checking at 8 and 12 weeks, 6, 9, and 12 months, and thereafter every 4 months. So we'll have to monitor the potassium. That is very important. This was the first approach in 2017. The 3 drugs used to start: ACE inhibitor, ARB, and beta blocker and MRA3. Then we reassess the symptom and substitute ARNI or for ACE inhibitor ARB. But coming to the ESC 2021, the management of heart failure, MRA is recommended for patients who have reduced to reduce the risk of heart failure hospitalization and death class 1A. And as we all know, the 4 pillars, they are ARNI, beta blocker, MRA, and SGLT2 inhibitors. Initiate all drugs, optimize, and reassess. This is what 2022 GDMT algorithm that shows in stage 1 at risk of heart failure, it has been found to be beneficial, but it's not there in the guideline. Guideline shows heart failure reduced ejection fraction less than 40%, MRA is class 1. And with rejection fraction 41 to 49 or more than 50, it is 2B, but is more helpful if the patient is less than 50% of ejection fraction. So MRA, ESC 2021, SEC, AHA, or Heart Failure Association of America 2022. This is EF less than or equal to 40%, class 1, mid-range, ejection fraction 2B, and also preserved ejection is 2B. So how should we consider starting a drug? We look at the blood pressure. If the patient is having high BP or low BP, less BP reduction with SGLT2 inhibitor and MRA. So volume status, whether the patient is having volume overloaded or euvolemic, kidney function, serum potassium, all these things to look for before starting the drug. This was the conventional sequencing like ACE inhibitor, beta blocker, MRA, ARNI, and SGLT2 inhibitor. Now proposed sequencing by Packer and McMurray plus beta blocker and SGLT2 inhibitor, then step 2 is ARNI and step 3 is MRA. However, now it is rapid sequencing. You will have to start all 4 foundational drugs, that is SGLT2 inhibitor, MRA, ARNI, and beta blocker. And on day 1, try to initiate a low dose SGLT2 inhibitor in the targeted dose at 10 milligram, or then low dose. Gradually, over 7 to 15 days, continue and try to up-titrate and look at 14 to 28 days, 21 to 24 days, 21 to 42 days. With this, you should optimize all the medications to the highest tolerable targeted dose. And after that, monitor and assess. This is how we will have to go for. What is the benefit of rapid sequencing? Rapid improvement in the health status, rapid reduction in heart failure, rapid reduction in mortality, rapid improvement in ejection fraction, rapid reduction in heart failure rehospitalization, and improvement in adherence to medications is also better. Therefore, to summarize, MRAs have demonstrated strong evidence to be considered as one of the pillars of heart failure management. MRAs have demonstrated low risk of death and hospitalization in heart failure patients. MRAs have also demonstrated a low risk of death and hospitalization in heart failure patients post-myocardial infarction. MRAs have also lowered risk of mortality and morbidity in severe heart failure patients. Monitoring for hyperkalemia is essential in patients on MRAs. It can be anticipated over next several years that use of non-steroidal MRAs such as Finerenone and or use of potassium lowering agents such as patiromer will be increased, and use of MRA in patients with heart failure, especially those complicated with advanced kidney disease or diabetes mellitus, potentially leading to a further decrease in cardiac mortality, hospitalization for heart failure, healthcare cost, and patient well-being. Thank you. Thank you for the patient hearing.